very important. And our speaker for today is she do a lot of simulation in Asia. It's very popular from the country. So she's from the Philippine General Hospitals, and she graduated from the Toronto for the cardiothoracics, and also graduated from the medical simulation fellowships from University of Western Ontario, Canada. So please welcome Dr. Grace Catalan for the clinical simulation in cardiovascular anesthesia crisis management for 15 minutes. Please, Dr. Grace Catalan.
Thank you very much, Professor Surapong. Good afternoon, everyone. If I may share my screen. Okay, can everybody see that? Okay, thank you. So good afternoon once again. So I would like to thank Dr. Nian and also Florian Nuevo for giving me the privilege to participate in this CME webinar. Thank you so much. And so our topic this afternoon is on teaching and training. It's on crisis resource management simulation in cardiovascular anesthesia. So I have no conflict of interest to declare. And so in the next 15 minutes, here are our learning objectives as clinicians and educators. I hope we will have a better appreciation of the value of crisis resource management skills in cardiac anesthesia training and practice, and also to consider the multifaceted elements of SIM-based education and crisis resource management skills in the development of training in perioperative cardiac teams. So let me begin by reviewing with you what we already know. This information has been here for the past decades, and it came from cardiology, cardiothoracic surgery, and cardiothoracic anesthesia. And this is about perioperative teams in cardiac surgery and the role of crisis resource management simulation. Again, just to summarize, simulation-based education enhances learning of technical and non-technical skills, or what we call crisis resource management skills in anesthesia. And what is important is to realize that this involves interprofessional and multidisciplinary teaming in order for us to improve clinical practice. Again, very important to keep in mind the debriefing part of simulation. This is where the learning and the reinforcement of learning happens. And here we need to have facilitators who are equipped in debriefing in simulation. And likewise, we need high fidelity crisis resource management simulations. And when I say this, I don't mean technologically advanced or highly technical equipment in order to produce high-fidelity simulation scenarios. Especially in resource-limited setting, we can present high-fidelity simulation even with what we call low-fidelity or equipment of low technology. And finally, since we are teachers and educators, we need to find out if what we're teaching is actually being achieved. And in the literature, there are several assessment tools that you can use. But what has been found to have good correlation with actual clinical performance and whose tool has good construct validity and reliability are the observational team in surgery, as well as the no-text, or this is your non-technical skills tool that has been found, like I said, to have good construct validity and reliability. So by way of review, very quickly, let's look at the crisis resource management behavioral skills that we are looking at. But today we're going to focus on the two most important ones that impacts team performance. And these are communication and teamwork. The rest, of course, are equally important. Situational awareness, anticipation and planning, resource utilization, and workload distribution. But what the literature says is that communication failures are actually the root cause of 65% of sentinel events, and this is from the Joint Commission of 2004 and 2012. And it is also the leading contributor to errors in medical practice. Again, in cardiac surgery study, they found that teamwork failures are more common with unfamiliar teams. So there is a need to be really communicating and having a good collaboration with your team. And a recent study of education of cardiac surgery team, they were able to identify 2 priority areas for improvement. And number 1 is speaking up, especially about critical information. And the second is clear communication, what we call closing the loop. So these are really important considerations when you are formulating or when you are conducting your CRM-based, simulation-based CRM skills training. Now, let's talk about teamwork, or what we also know as interprofessional or interdisciplinary collaboration. And the World Health Organization defined this as multiple health workers from different professional backgrounds working together with patients, families, and colleagues to deliver the highest quality of care across all clinical settings. So this is really important. Okay, and there are core competencies that we look for or we strive for when we do interprofessional collaboration training. And these are the ability to be able to demonstrate values and ethics for interprofessional practice while working with others, understanding roles and responsibilities, fostering interprofessional communication, and performing effectively as a member of the team. Now, let's segue now to my home country, and let's look at the perspective of the simulation-based education in cardiac surgery teams in the Philippines. So we are in the Southeast Asia. The Philippines has about 110 million population spread across the 7,000 plus small islands. So we are a lot, okay? And the history of simulation-based education and training in anesthesiology in the Philippines is quite new. We began in 2015 by introducing simulation activities, and then we moved on by not only conducting simulation activities, but conducting training for trainers to equip clinicians and simulationists to become better facilitators and to be able to set up their own simulation program. We also lobbied for the integration of simulation-based education in the anesthesiology curriculum. And as of 2021, it has been integrated as part of a teaching strategy in the anesthesiology training program in the Philippines. Now we have created a group. This is a special interest group. We started with a community of practice where simulation enthusiasts came together, and also those who had experience and expertise in the field of simulation. And then, like I said, we began conducting simulation sessions and then training of trainers. We had sessions on debriefing skills training. And then right now, we're setting up simulation activities to help the different training programs set their own simulation activities in a low resource setting. Now, just to give you an overview of what we have done so far in the field of cardiac surgery team in the Philippines. So we started way back in 2020. This was the time of the pandemic when we had our crisis resource management simulation for perioperative cardiac teams. And we moved on to the cardiac surgery advanced life support activities, recognizing that post-cardiac surgery patients require a different set of skills and a different algorithm in terms of managing advanced life support. So we pilot tested this activity at the University of the Philippines, Philippine General, which is the tertiary referral center and the National University Hospital. So we admit about more than 500,000 patients a year, but for cardiac surgery, we are a low volume center. We do about 300 cases a year, but these are really complex and varied cases as we are the primary referral center in Manila. And we also introduced the program at the Heart Center of the Philippines, which is the Philippine Heart Center. This is where the bulk of the cardiac patients go to, and they do a lot of surgery. They do high volume cardiac surgery here. It's more than 3,000 cases a year. And so you can imagine the importance of cardiac surgery, advanced life support skills, and CRM skills in these institutions. Okay. So this is these are some of the pictures I was able to gather. So this is an interprofessional collaboration. We had cardiac surgeons, cardiac anesthesiologists, operating room nurses, intensive care nurses, intensivists, and perfusionists, all in one team. And this is a half-day activity where we conducted different crisis management scenarios involving the perioperative care of cardiac patients. All right. So this was conducted both at the Philippine General Hospital and the Philippine Heart Center. How did we come up with a high-fidelity simulation? With the use of 3D printers, which we fashioned ourselves, we were able to create, for example, moulage of chest wall for emergency sternotomies. We were also able to 3D print hearts so that we can make the high fidelity and more realistic simulation for our scenarios. There is an available app. This is commercially available. This is a vital sign simulator, and this actually improves the realism and fidelity of the simulation scenario. So as educators and clinicians and as simulationists engaged in crisis resource management skills training, what are our challenges right now? So we look at fidelity and realism in a resource-limited setting. But like I said, you do not need high technology or specifically high advanced technological equipment and mannequin in order to create this. Remember that fidelity is not only on your simulators, but it also consists of the environment as well as the context and the contents of your simulation scenario. We need to train our simulation enthusiasts on how to debrief properly, because this is where the learning happens really. Now, scheduling and sustainability is very difficult because we're talking about interprofessional teams. You know, asking a cardiac surgeon or an intensivist to take time out and spend 2 to 4 hours of simulation is a little bit difficult. So that scheduling becomes variable and sometimes inconsistent. And again, resources and remuneration. For us, educational activities is translated into loss of clinical hours, and this is very important as well. Having challenges, I want us to focus also on opportunities. So we live in a digital world. We are interconnected so that access to information, access to different simulationists across the globe can happen easily. So we can collaborate with other teams, we can collaborate with other groups in creating more of this interprofessional simulation. Now, the thrust of education, of course, is learner-centric and patient-centered. And here is where the role of simulation becomes very crucial, because all the skills in learner-centric education and patient-centered care are focused on non-technical skills. Now, lastly, some special considerations when you're putting up or when you're doing your simulation in crisis resource management. The Society for Simulation in Healthcare has published recently some of the scenarios for skills training in cardiac surgery teams. And this was done by a group of cardiothoracic surgeons at the University of Amsterdam. I just want you to see that a lot of the crisis scenarios here involves perfusion team. So we really need to create and strengthen our cardiac surgery team, including perfusionists. Another thing is that cultural considerations, especially when we're doing cross-border curriculum partnerships. Now, in international meetings, we have simulation sessions, but we always have to take everything in the context of different cultures because this can become a risk or sometimes a challenge as well in drawing out learners and participants. Skills decay will dictate how often should you do your simulation. You can do different strategies depending on what type of simulation you are doing. So you can do mastery learning to just-in-time training for booster skills training. And finally, the culture of safety or the safety culture, which is now a very big thing for us. And if you look at the definition of safety culture, it really means team collaboration and also communication. So these are the ways where you can develop safety culture. You need teamwork, you need training, and you need organization and involvement of each member of your team. So in summary, what are the implications for the 21st century educators? I would like to focus on simulation education. We have to make our simulation sessions more learner-centered, and we can look at the strategy of rapid cycle deliberate practice. And for those who have the resource, you can do virtual reality or virtual simulation. So I would like to end by saying that simulation-based education creates transformational learning experiences. Here are my references, and thank you for your time and attention.
Thank you very much, Dr. Grace Catalans. It's a fantastic summaries. Enjoy many international meetings, and some meeting end up with the simulations, and the feedback of that meeting is always like it's like the good feedback for the summarizations of the academics for the whole meetings, because the simulations is make it real. So for my summarize from your talk is like high fidelity simulations and realism is very important. What is because we are all around Asia, we different in many countries. Some country may not have very sophisticated high fidelity simulations. How can they start like launch the simulations without the high fidelity simulator? In your opinion, please? What is the most important?
You can start with low fidelity simulations. For example, you can start with pen and paper. You can do computer-based simulation, meaning to say that you just come up with a scenario and then you can talk to your learners about this. But what they found out is that for team training, you really require high fidelity simulation. What we advise is that we partners with some distributors of mannequins, which you can do. Of course, it cannot happen on a regular basis, but you can do that. And then the technology that I introduced a while ago, if you have a 3D printer or you know someone who has a 3D printer, you can just Google some of the parts that you like and then collaborate with them, and you can actually make your own simulators with these 3D printers. So you can start from there. And of course, Professor Surapong, very important is we need to equip our facilitators. And like I said, in the Philippines, we started, just conducting simulation and then pick up those doctors or clinicians who are interested in simulation. And slowly we build up our education as facilitators of simulation. And then we send them to Singapore where they have this they have these courses on simulation. Yeah.
Thank you very much, Dr. Grace Catalans. So now we move to the next topic, and if you guys from the online, if you have the questions, you can continue to chat in the questions Q&A questions, and then we will come back to ask the question later. So I would like to move to the next sessions. The next sessions we will move to the speaker from Vietnam. I'm very happy to have the speaker from Vietnam this time because she is from Ho Chi Minh City and she is very important person. She helped a lot of educations and developments in Ho Chi Minh and in Vietnam and also in Southeast Asia. She is a cardiac anesthetist from Ho Chi Minh City, and her talk will be on the thing that we have a lot of problem during pediatric cardiac surgery because the pulmonary hypertension is very difficult situations and important and relate to mortality. So how can we pass through this, the pulmonary hypertension in congenital heart disease? So please welcome Dr. Gui Tai Nguyen, please.
Yeah, thank you, Dr. Surafong. Good afternoon, everybody from Ho Chi Minh City. Thank you for having me. Thank you, Dr. Ni Chen Huan, President of the Asian Society of Cardiothoracic Anesthesiologists, for inviting me. Thank you for Dr. Surafong for your kind introduction. And thank you, everybody. My talk today is is a very operative anesthesiological management of pulmonary hypertension in children with congenital heart disease. I share. Pulmonary hypertension is defined as mean pulmonary arterial pressure greater than 20 millimeters mercury. And the severity of pulmonary hypertension is classified into 3 levels: mild, moderate, and severe. And according to WHO, the pulmonary hypertension is classified into 5 groups. And this is the different subgroup of pulmonary hypertension in congenital heart disease. And in group 1, pulmonary arterial hypertension, including Eisenmenger syndrome, pulmonary arterial hypertension with congenital heart disease with left duration, PAH with small defects, and PAH after congenital heart disease correction. And group 2, you can have acquired or congenital left heart disease, including pulmonary vein stenosis, mitral stenosis, aortic stenosis, or coarctation of aorta. In group 2 is pulmonary artery obstruction. And group 5, we can have a single ventricle with pulmonary hypertension. After cavopulmonary anastomosis, like a Glenn or Fontaine procedure, understanding the underlying cause, subgroups, and severity of pulmonary hypertension allows anesthesiologists to make a comprehensive anesthesia management plan to reduce patient-related risk. Children with pulmonary arterial hypertension and congenital heart disease pose anesthetic challenges because of their high risk of perioperative morbidity and mortality. Perioperative management of these patients should focus on supporting the patient through to the vulnerable periods of physiologic derangement surrounding surgery. Acute alteration in pulmonary blood flow, alter pulmonary endothelial function following cardiopulmonary bypass, invasive mechanical ventilation, adaptation to new hemodynamics following correction or palliation of congenital heart lesion. These patients require careful attention on every step of perioperative management by an experienced team. Children with pulmonary arterial hypertension who has undergone non-cardiac surgery or cardiac catheterization demonstrated incidence of major complications and deaths that are many times greater than those reported in all children undergoing surgical procedure. The severity of baseline pulmonary arterial hypertension correlated with the incidence of major complication. Children with suprapulmonary arterial pressure are 8 times more likely to have major perioperative complications than those with subsystemic pulmonary hypertension. Another study showed that more than 2,000 infants and children undergoing cardiopulmonary bypass for repair of congenital heart disease concluded that preoperative pulmonary hypertension was a significant risk factor for postoperative in hospital death. There are many risk factors, anesthetic factor, hemodynamic factor, surgical factor, and patient factor that to identify pediatric at high risk of perioperative complication. But 3 risk factors commonly identified as predictive of increased perioperative morbidity in children are suprasystemic pulmonary hypertension, age less than 1 year, and the complexity of the procedure. Therefore, preoperative anesthetic management, including comprehensively assess the severity of pulmonary hypertension, minimize preoperative hypovolemia, avoid anxiety, pain, and sympathetic stimulation. Premedication effective for CAM induction, we can use oral or IV midazolam premedication. We should avoid oversedation and hypoventilation. Continue pulmonary vasodilators agents currently used to control pulmonary pressure. Before taking the children into the OR, we should prepare emergency drugs available like epinephrine or inhaled NO. ECMO on standby depending on the severity of the children. The key anesthetic principles including balanced anesthetic technique, airway, and ventilatory support. We should avoid triggers of pulmonary hypertensive crisis. Preoperative operative inhale selective pulmonary vasodilator, appropriate monitoring, and maintain hemodynamic stability such that the risk of RV ischemia is minimized. The ideal anesthetic drug for children with pulmonary hypertension would have pulmonary vasodilator effects, not impair cardiac contractility, maintain SPR and cardiac output, and have short-lasting and be easily titrated. Unfortunately, such an anesthetic does not exist. To minimize the undesired hemodynamic effects, it's better to use a balanced anesthetic technique. Combining sub-anesthetic doses of multiple anesthetic to achieve a good anesthetic state. To provide adequate anesthesia and analgesia. Minimize nausea, stimuli, pain, tracheal suction, and agitation. Induction of anesthesia by combining opioid like fentanyl or remifentanil with propofol or midazolam, ketamine, or dexmedetomidine. Low concentration of sevoflurane can be used as can be used for induction. Maintenance of anesthesia by combining intermittent fentanyl doses with sevoflurane are usually widely used. We should provide nitrous oxide because due to increase the PVR. Muscle relaxant with rocuronium, becuronium are used safely. We should avoid hypotension by starting vasopressor early. Careful with stress responses during intubation. Basic monitoring includes ECG, oxygen saturation, capnography, invasive blood pressure, and CVP. Echocardiography is a non-invasive assessment of the patient with pulmonary hypertension. Both TTE and TEE are used as intraoperative monitors. Monitoring hemodynamic management including maintain sinus rhythm, systemic blood pressure, optimize RV function and cardiac output. Consider pulmonary vasodilators to decrease RV afterloads. Optimize fluid balance, aggressively treatment hypotension. In children with RV hypertrophy, hypotension can lead to decreased coronary perfusion and acute RV failure. Because that's judicious use and early initiation of vasopressor often recommended for hypotension occurs during perioperative. Ventilation management principles include adequate oxygenation, moderate hyperventilation, avoidance of acidosis, and maintain plateau pressures less than 27 centimeters of water via low PEEP and low tidal volume. Post-operative consideration including what we should encourage and what we should avoid. The primary goal is reduce PVR, support RV function, maintain stability, hemodynamic, and cardiac outputs. The key measures include analgesia and sedation, ventilation, inotropic support, and vasodilators, and pulmonary vasodilators. This is the medicament we can use for treatment pulmonary hypertension in intensive care units. Pulmonary incident of post-operative pulmonary hypertensive crisis occurs at 0.7 to 4%. Several factors contribute to decreased incidence. Performing surgical correction of congenital lesion at a younger age. Improve surgical technique and the practice of cardiopulmonary bypass. Despite its incidence is decreasing, PHC still accounts for a significant portion of mortality after cardiac surgery. And PHC can lead to acute increased PVR, then can lead to acute RV failure. Decompensation, right heart failure, cardiogenic shock, and even death may occur due to PHC. If cardiac arrest occurs, CPR may be ineffective because enlarged RV size. And PSC can happen anytime during perioperative time. The treatment of pulmonary hypertension crisis including administer oxygen 100%, hyperventilate, exclude pneumothorax, decrease mean airway pressure, correction of metabolic acidosis, administer pulmonary vasodilator with inhale NO or iloprost, support the cardiac output with adequate preload, cautious volume, and inotropic support. Mechanical cardiopulmonary support with ECMO should be considered early for refractory pulmonary hypertensive crisis. Support coronary perfusion by maintaining SPR with epinephrine or norepinephrine. Adequate analgesia. Conclusion, careful assessment, preparation, and coordination between discipline before, during, and after surgery are essential to reduce risk and optimize outcome. And physician knowledge of available treatment option, pathophysiologic, and the effect of various anesthetic agents and techniques are essential to ensure the highest level of patient safety and care. Thank you for your attention.
Thank you very much, Dr. Cui Tai Nguyen. Now we are open for the Q&A from the attendants. Please forward your questions to the chat box.
Yeah.
And in the meantime, we're waiting for the questions. In pediatric, the measurements of the pulmonary hypertension is just like in adult that we can measure the PA pressure from one gans or another, because for pediatric we can measure before the operation, but during the operation, how can we measure? How can we know that these children have the pulmonary hypertension in case that we don't have some parameters? So in your clinical practice, what you have a look for, echo or another, please?
In my institution, in my hospital, many years ago, we didn't have echocardiography transesophageal. So for some difficult case with severe pulmonary hypertension, and we need to monitoring the pulmonary arterial pressure very in postoperative. So we need to put the pulmonary arterial catheter by the surgeon. They put the catheter into the pulmonary artery transthoracic. We can do the Schengen for the small children. But recently we have the echocardiography with TEE transesophageal, and we can do with this echo, we can monitor the patient before, during, and after operation when we need. So it's more and more we don't use the pulmonary artery catheter for the children. Yeah.
Thank you very much. And another question from the attendant is, sometimes when we have the situation of pulmonary hypertension, we would like to reduce the pulmonary hypertension by do the hyperventilations. But sometimes if you do hyperventilation too fast until we have hypocarbia and the cerebral perfusion is reduced, and they're concerned about the brain protections. So what is the target of the PaCO2 for the hypocarbia, please?
Yeah, because when we adjust the ventilation with moderate hypertension, we maintain the PaCO2 around 30 to 35 millimeters of mercury. It's just for the the decreased PVR in the patient with pulmonary hypertension.
Thank you very much. So
Thank
we
you.
may move. Thank you very much, Dr. Gui Thai Nguyen. And we are moving for the next sessions, but we can continue discussions in the Q&A box, and the speaker can answer your questions in the chat box and or maybe later if we have time. So thank you very much and move to the next session. Thank you very much.
Thank you, Dr. Surapong.
Thank you, speakers and Dr. Surapong. Dr. Liang Ka will moderate the next session, and he will introduce Smith3 and himself. Dr. Liang Ka.
Yes. Thank you very much, Dr. Huang. For the next session, we will start off with two sessions. I'll follow in the second section, but it's a great opportunity now to introduce the first speaker in this session, Dr. Smriti, who's from Kathmandu in Nepal. And she's going to talk about something that's very important in the perioperative period, which is on perioperative delirium in cardiac surgery patients. She's going to explain to us understand the predictors to reduce incidence and to improve outcomes, to reduce the incidence of delirium in cardiac surgery patients. So without further ado, Dr. Smriti, please carry on.
Good afternoon, everyone. So it is truly an honor to be here today to discuss this critical and often under-recognized issue, postoperative delirium or POD in cardiac surgery patients. So I would like to take this opportunity to express my sincere gratitude to Dr. Nguyen and also Asian Society of Cardiothoracic Anesthesia for giving me this platform to discuss this vital topic. So POD is a multifaceted condition that significantly impacts patient outcome and presents substantial challenges for healthcare system on a global scale. As a cardiovascular anesthesiologist at Syed Gangalal National Heart Center, I have witnessed firsthand the profound effects that POD can have on patients undergoing cardiac surgery. So let's begin by addressing a fundamental question: why focus on POD? So POD is not merely a transient cognitive disturbance. It is a serious complication with far-reaching implications for patient, families, and healthcare systems. So understanding its prevalence, outcome, and modifiable risk factor is key to recognizing the critical need for proactive intervention. Among cardiac surgery patients, the incidence ranges from 15 to as high as 50%, and it is associated with 30-day mortality rate of 7 to 10%, underscoring its significant effect on immediate post-operative survival. Additionally, it leads to prolonged ICU stay, hospital stay, contributing to increased healthcare cost and resource utilization. The risk, however, extends well beyond the immediate post-operative period, which has been linked to long-term cognitive decline and increased mortality. So what makes POD particularly important to address is the presence of modifiable risk factor. Many of these factors contributing to delirium can be mitigated through the targeted evidence-based intervention. So this presents us with a valuable opportunity to reduce the incidence of POD proactively. So I aim to provide a clear and updated understanding of POD from its underlying causes and risk factor to evidence-based prevention and management strategy, ultimately identifying actionable solution for the better patient outcome. To start, let's take a moment to define POD. It is an acute fluctuating disturbance in cognitive function that typically arises in few hours to few days, usually between postoperative day 2 and 5 following surgery. It is characterized by changes in attention, awareness, and cognition, often presenting as confusion, disorientation, or difficulty concentrate. concentrating. So there are three distinct forms of POD. Hyperactive delirium marked by restlessness, agitation, and even hallucination. Hyperactive delirium exhibit lethargy, slowed response, and reduced engagement. It is often underdiagnosed because the symptoms are more subtle, and mixed delirium where patients alternate between the hyperactive and hypoactive form. So here this chart illustrates the incidence of postoperative delirium across different types of surgery. The risk of POD is closely associated with the complexity and urgency of the surgical procedure. Elective and less invasive surgeries show lower incidence, while high risk and emergency surgeries demonstrate the greatest vulnerability to delirium, with estimates reaching up to 70%. Let's now explore the pathophysiology of POD. This mechanism includes neuroinflammation, cerebral hypoperfusion, and neurotransmitter imbalances. Neuroinflammation with elevated level of inflammatory markers such as CRP and interleukin-6 comprise the integrity of the blood-brain barrier, allowing harmful substance to infiltrate the brain and impair the neural function. And during complex procedure like cardiopulmonary bypass, brain perfusion often decreases, increasing their vulnerability to delirium. And a deficiency of acetylcholine is associated with deficit in memory and attention, and excess of dopamine can contribute to the confusion, agitation, and other cognitive disturbances. So now coming to the risk factor, preoperative factors play a significant role in the risks of POD, underscoring the need for comprehensive preoperative assessment and risk stratification. Advanced age, particularly patient over 65 years, is one of the strongest risk factors for POD, as aging reduces the physiological reserves and increases vulnerability to neurocognitive disturbances. Carotid artery stenosis poses a risk due to compromised cerebral blood flow, and chronic conditions like diabetes and hypertension contribute to the systemic inflammation and vascular changes, disrupting the normal brain function and increasing POD risk. Pre-existing cognitive impairments, severe cardiac dysfunction, anemia, all exacerbates the risk of POD. Intraoperative factors are key in minimizing neurocognitive disturbance. Prolonged cardiopulmonary bypass time are strongly associated with increased POD risks through neuroinflammation and hypoxia. Both inadequate and excessive anesthesia, hypothermia, surgical complexity, and blood transfusion further elevate these risks. And optimizing these factors can significantly reduce the POD incidence. Postoperatively, prolonged ICU stay increases immobility, stress, and sedation, all heightening the risk of POD. Extended mechanical ventilation, hypoxia, sleep disturbances further impair the cognitive function. Sedation, especially benzodiazepines, exacerbate the POD by disrupting the cognition and neurotransmitter balance. So early mobilization, optimizing oxygenation, and minimizing sedation can significantly reduce POD and enhance recovery. So in our study, we found that postoperative delirium affects around 15.6% in our cardiac surgery patient. That's about 1 in 6 patients. And we identify key risk factor in 3 stages: before surgery, older age, carotid artery disease, and hemoglobin less than 10 increase the risk. During surgery, longer bypass time and blood transfusion played a role. And after surgery, prolonged ICU stay, longer mechanical ventilation time, sleep deprivation, PaO2 less than 70, all contributed to the higher risks of POD. The good news is many of these factors are modifiable. So by addressing them, we can help reduce the burden of POD. So our study reported POD incidence of around 15.6% compared to other studies, which shows the rates as high as 52%. And so this suggests potential differences in patient selection, surgical protocol, warranting further investigation. And we identified hypoxia and sleep sleep deprivation as the key modifiable contributors to POD. Interestingly, unlike other studies, we found no significant association of POD with factors like NYHA grade, renal dysfunction, or atrial fibrillation, and pain score above 5. So effective POD management involves 4 key areas: risk stratification, risk reduction, early diagnosis and treatment, a comprehensive approach to improving the patient outcome. So risk stratification before surgery with cognitive assessment like Montreal Cognitive Assessment to identify the high-risk patient. Those with older age, cognitive impairment, cerebrovascular disease also needs closer monitoring. Validated tool like CAM helps detect delirium early and predict POD risk. So guiding early intervention. So by identifying and addressing these risks early, we can take proactive steps to reduce POD and enhance recovery. So we have a different delirium scoring methods commonly used in ICU. In our study, we used CAM ICU as it is quick and simple tool for assessing delirium in non-verbal patient as well. So selecting the appropriate tool depends on the ICU setting and patient profile, and combining the multiple tools can enhance the delirium detection. So coming to intervention, preoperative planning is critical to reducing POD risk. First, assessing baseline cognitive function help identify any cognitive changes post-surgery. A thorough medication review is essential to adjust or discontinue drugs like benzodiazepines, scopolamine, which increases the POD risk, and managing chronic condition as already discussed, and ensuring a comprehensive geriatric assessment provide a holistic view for the older patient, and avoiding prolonged fasting using opioid-sparing analgesics for pain management are key. Multidisciplinary approach ensures optimal care planning. So key intraoperative strategies include minimizing CPP time to reduce brain injury risks, monitoring cerebral oxygenation with oximetry to ensure proper brain function, and using anesthetic depth monitoring with BIS to prevent under or over sedation. Maintaining stable temperature and pH helps avoid complications like cerebral hypoxia or ischemia. Additionally, multimodal pain management reduces the opioid use, and stable hemodynamics further minimizes the delirium risk. Emerging pharmacological interventions show promise in preventing POD. Dexmedetomidine reduces the stress hormone and improves sleep, beneficial in both cardiac and non-cardiac surgery. Other drug ketamine offer neuroprotective and anti-inflammatory effects. Paracetamol and NSAIDs provide safer alternative to opioids to reduce neuroinflammation, and minocycline, an antibiotic with anti-inflammatory properties, shows promise in animal study, though further research in human is needed. So postoperative delirium management includes both non-pharmacologic and pharmacologic strategies. Non-pharmacologic approaches such as reorientation, cognitive exercises, optimizing vision and hearing, and sleep enhancement have proven effective. And combining these strategies in multi-component care package can reduce the delirium risks by up to 50%. And pharmacological intervention like melatonin help regulate the circadian rhythm and reduce inflammation, though the evidence here is mixed. And high-dose dexamethasone has shown a 20% reduction in delirium incidence, but its safety in non-cardiac patient remains uncertain. And the other drug shown effective is dexmedetomidine. So for managing established POD, this requires careful diagnosis and treatment, starting with underlying causes such as infection, pain, dehydration, electrolyte imbalances, or metabolic disturbances. And for severe agitation, antipsychotics like risperidone, olanzapine, or haloperidol can be used, but they carry risks, especially in the elderly, and may not shorten the delirium duration. So this medication should be used sparingly with careful monitoring to balance the risk and benefits. So implementation of the effective intervention for POD has a profound impact on the immediate and long-term patient outcomes. In the short term, these interventions significantly reduce the incidence of delirium, leading to quicker recovery, shorter ICU and hospital stay, and decreased need for mechanical ventilation. And long term, this intervention results in faster recovery, better quality of life, fewer hospital admission, and lower healthcare costs. So despite progress in understanding and preventing POD, key research gap remains. Much of the current research is based on small single-center studies, limiting their generalizability. And additionally, further studies are needed to explore the link between hemodynamic parameters and delirium, as well as long-term effect on cognitive function, emotional well-being, and quality of life. So sharing knowledge and fostering collaboration across healthcare centers is key to improving POD prevention and management. By standardizing evidence-based protocol, we can ensure consistent, high-quality care for all patients. So key takeaways from my study. This is a busy slide, so I've tried to fit in all the strategies that we have made in our settings. After conducting my research, so I realized how critical it was to identify patients at higher risks for delirium. So we now prioritize elderly patients more than 60 years, those with carotid artery disease, and patients with hemoglobin level less than 10. And one of the most significant changes we have made is ensuring that patients above 60 years undergo a preoperative cognitive assessment using mini-mental state examination to get a baseline. And we also ensure we review the patient's complete medical history, particularly looking at smoking, alcohol use, chronic condition like diabetes and hypertension. So based on this assessment, we classify patients into the low, medium, and high risk categories. And in terms of risk reduction, we have made several adjustments across the perioperative period. Preoperatively, we have started addressing anemia more aggressively. So patients with low hemoglobin now receive transfusion or iron therapy well before surgery. And we focused on reducing the bypass time by optimizing the surgical techniques and using the restrictive transfusion protocol. So another major addition is the intraoperative epiaortic scanning, so which helps to assess the atherosclerosis to reduce the risk of embolic stroke during the surgery. And post-operatively, we have worked with the ICU team to improve the environment. We usually dimmed all the lights and reduced noise at night to improve the sleep quality. And we've also introduced the multimodal pain management, reducing our reliance on the benzodiazepines and opioids. And we aim to start our physiotherapy within 24 hours of surgery to encourage early mobilization. And those who are categorized into high risks, we now allocate as much as possible 1:1 nursing care in the post-operative period to allow for continuous monitoring and early intervention. And in early diagnosis, early detection has been a priority. So we do daily assessment using CAM ICU to track any signs of confusion or agitation. And during daily rounds, the team look out for subtle behavioral changes, which can be reported by nurses, families, or on-duty doctor. And so if delirium is suspected, we promptly investigate the potential causes like hypoxia, electrolyte imbalance, and infection. And for treatment part, we focus on the non-pharmacological intervention, like regularly orienting patient and involving the families in their care to provide reassurance. And we make sure to maintain optimal oxygenation, hemoglobin level, and when sedation is necessary, we prefer dexmedetomidine. So I would like, as coming to the conclusion of today's session, I would like to take a moment to again sincerely express my gratitude to all of you for your time. And I would like to extend a heartfelt invitation to all the delegates to visit the Nepal. Thank you once again.
Yes, thank you, Dr. Smithy. It was really good presentation, very clear.
Thank you. Thank you.
So I have the pleasure of introducing myself for the second talk. Let me see whether I can do this. Oh, I can't. So my name is Lian Kati. I'm a cardiac anesthetist in National University Hospital in Singapore. And let's see how I'm going to do this.
Click one more time.
Okay.
The slideshow, click one more time.
Yeah, I can't get to. Okay, got it. Okay, great.
Yeah.
So I think after the previous presentation, the second presentation is on acute kidney injury, and as you know, if for cardiac surgical patients who have to stay back have a prolonged hospital stay and readmission to ICU, the three major causes are delirium, acute kidney injury, and atrial fibrillation. So today we will talk about two of them. I think Dr. Smithy had really given a really good overview of the issue with delirium, and I want to share another problem that is quite important, which is of course acute kidney injury. Okay, so basically I'm going to explain to you what cardiac surgery associated AKI is, what do our guidelines currently say, and a trial that I was a part of, the protection trial, and introducing the possibility of treating or preventing acute kidney injury with amino acids. Now, we know that AKI is common, right? 7 to 40% in large cohort studies. In fact, in Singapore, when we did a cohort of over 3,000 patients, and this was done about 10 years ago, almost 30% developed AKI. And importantly, we followed these patients up after 5 years after they were discharged from hospital, and we found that there are risks of having these are patients who are not on dialysis prior to surgery, but if they develop AKI, there are risks of having a need for dialysis, a new need for dialysis after a median of 4.5 years, went up by 470%, or 4.7 times. And you can see from the cartoon on the right that acute kidney injury actually not only leads to short-term outcomes, but to prolonged long-term outcomes beyond what happens to the kidney. It does affect cardiovascular morbidity, stroke, infections, fractures, and the well-being overall. And of course, all this drive up healthcare costs. So what is AKI? AKI associated with cardiac surgery is characterized by a rapid decline in glomerular function, kidney function. Basically, all the AKI, whether it's from ICU or from nephrotoxic drugs or from oncology and from anesthesia, they all have converged using the same guidelines, which is the same measuring tool, which is the KDIGO definition, and that makes it easy for us to look at what other people are doing in other fields, and also to see the things that affect in our field can also affect, even if you are in ICU, and the things that happen in cardiac surgery is pretty similar to that in ICU, even though the etiology may be a bit different. So if you remember the KDIGO guidelines, which is now the standard guidelines, the 2012 KDIGO guidelines states that you can classify AKI into 3 stages based on the increase in serum creatinine, whether it's a 50 to 100% rise in serum creatinine, 100 to 200% rise in creatinine, or over 200% rise in serum creatinine on the stages. There's also a secondary criteria based on urine output. Usually for cardiac anesthesia and cardiac surgery, we don't use this criteria because, as you know, a lot of patients may have quite a significant fluid changes during that period. So this may be relatively less accurate. But regardless, this is the KDIGO classification that is used uniformly. So this appeared in the January edition of the Lancet. This talk about the pathophysiology of cardiac surgery associated AKI, and you can see cardiopulmonary bypass plays a really big role in it, in both causing ischemia, reperfusion injury, as well as hemolysis. It also contributes to inflammation, oxidative stress, and during the period of hypotension and hemodilution and hypothermia, this all will then end up with vasoconstriction. And vasoconstriction through activation of the renin-angiotensin system will then lead to reduced renal perfusion, and this will then contribute to cardiac surgery associated AKI. There's also a possibility of embolus and nephrotoxic agents that we use during surgery, but the majority or the main driver of this cardiac surgery associated AKI is really vasoconstriction. So what do our guidelines say? Our guidelines are fairly recent. They were published in Anesthesia Annals of 2023. This was a guideline that was done in association with the Society of Thoracic Surgeons, as well as the perfusionists. They had two class 1 recommendations. The first one was, both of which are being done by your perfusionist. So if your perfusionists are not doing this, then you should make sure that they do this, because these are class 1 recommendations, which means that you should do this in every case. The first one is that you should avoid overheating the patient on the cardiopulmonary bypass circuit. Any temperature that's above 37 degrees at the arterial outlet, each minute increase incidence of CSA AKI by about 3% per minute increase. So it's a simple thing to do. Just don't overheat the patient to beyond 37 degrees. The second thing is, of course, now all perfusion machines, all cardiopulmonary bypass machines will have an automated calculator for how much oxygen delivery is given. And we know from studies that were done over 10 years ago that you have to avoid giving oxygen delivery of less than 280 mL per minute per meter square. And you can see that the formula is really dependent on pump flow, depending on your hemoglobin, as well as oxygen concentration. But this usually is done by a perfusionist, so you don't really have to worry about it. Just make sure they do it for every case. A class 2A recommendation says that you should adopt it if possible, right? And there's only one, which is to adopt the KDIGO practice guidelines. And the KDIGO practice guidelines is really based on the PREF-AKI trial, which was done in 2017. And what they did was they used a biomarker under the commercial name of NephroCheck. And what this biomarker does is that it will detect whether your kidneys are stressed, or your patient's kidneys are stressed after coming off bypass within 4 hours after surgery. And if your kidneys are stressed at that point in time, it's reversible, right? It's before there's permanent damage, where permanent structural damage to the kidneys occurs. So if you do a bundle, which is to optimize volume status, optimize perfusion, avoid nephrotoxic drugs, stop ACE inhibitors, and look for alternatives for iodine contrast agents, you can actually reduce the AKI by almost for in their study, all these are high-risk patients who already had renal stress, that means they had biomarker positive, from 71% to 55%. So a really dramatic reduction. The problem with the PREF-AKI study and the problem with the KDIGO bundle is that, of course, they had to use cardiac output monitoring to ensure adequate perfusion. And the issue is, of course, to do that, you actually need a cardiac output monitor, and it's either costly or very invasive. And the control group actually just used mean arterial pressure and CVP, which was not good enough. So this is a problem. It's definitely a class 2A recommendation, but it's pretty expensive and difficult to implement. There are also class 2B's recommendation, which means that there's some evidence that it works, but the evidence is not strong. So one of them is to use phenoldiazepam, which is a vasodilator. So as you remember, I told you that vasoconstriction is a very important cause. And what the people have tried to use a vasodilator like phenoldiazepam. The studies have been mixed, right? In cardiac surgery patients, it looks okay, but as long as hypertension is avoided, but when you look at AKI as a whole, including critical care patients, phenoldiazepam really doesn't work. The other one is, of course, to use a minimally invasive bypass technique. a closed system with a centrifugal pump, reduce primary volume, reduce inflammation, right? A meta-analysis suggested that MIC, using a minimally invasive circuit reduced the odds of CSA AKI by about 50%. But many studies have shown otherwise since then, including our own study where we showed that there was really no difference in our population, no difference between patients who had minimally invasive and a conventional cardiopulmonary bypass. And of course, the miniature system costs a lot of money. There was always a problem with venous return, and of course, we had to use a cell saver for every case, which was not standard at that point in time. So again, it's a 2B implication. It worked in some people, but not for us. There are also some class 3 recommendations, which is things that you should not do. One is dopamine. Dopamine does not work, right? In fact, it may cause potential harm. The other one is mannitol. Mannitol also does not work, as in most diuretics do not work. So what we know is that the measures and guidelines are primarily preventive, right? That doesn't really tell us anything really that we can do different from what we are already doing. And we know that even normal kidneys are stressed by cardiac surgery. And despite all the things that we do, even if we maintain normal mean arterial pressure, renal flow is commonly decreased. That's why you need to actually look at cardiac output. And when patients have vasoconstriction, the vasoconstriction is severe and very long sustained, usually due to depletion of ATP. And this results in tubular obstruction, then elevates serum creatinine, decreases cardiac output, cause granular cast. So prevention is the key. So that comes to the study that I'm going to tell you about, which is a study that I participated in. This was published August last year, where we did a RCT, a large international RCT, on the use of amino acids for kidney protection in cardiac surgery. So what this use is that they use the concept of that the GFR, the glomerular filtration rate, is usually not maximal in an unstressed state. And the GFR, in fact, can remain normal until loss of 50% of nephrons. As you know, patients who undergo a nephrectomy, sometimes even after post-nephrectomy, they can have a normal GFR. And how the body copes with it is actually a result of glomerular hyperfiltration of the remaining nephrons. And this is similar, I guess, in a way to our liver. If you reset part of the liver, you still have normal liver function. It's the same with our lungs. We always have some capacity for some reserve, we have some reserve in a GFR. Our GFR will increase in load of stimuli, and we have known for a long time that when you give patients protein or amino acids, their GFR will increase. During cardiac surgery, the major contributor to decreased GFR during cardiac surgery is really renal hypoperfusion. And CPB reduces renal blood flow by 50%, and then this will in turn cause hypoxia. So the key here is that why don't we tap on the renal functional reserve? The renal functional reserve is actually the difference between the peak GFR, which is basically whatever the kidney can produce, and the baseline GFR, which is what the patient is functioning on. And we know that there's at least a 40% increase. If you stimulate with the stimuli, you can measure this, usually protein load. So we know that the patients have a reserve here, right? One way to look at it, how it happens is that if we give amino acid or protein, we actually we have it's as if right now you can see the horses on the left, the two horses pulling work overload. Then we get more horses from the stable, and then we recruit more nephrons. Basically, have more nephrons doing the same load. Or at the same time, each of the horses actually, or each of the nephrons actually becomes more efficient. They become bigger horses. They're able to carry more and clear more glomerular filtration. So amino acids work in a variety of ways, right? They recruit the renal functional reserve, but they also reduce vasoactive mediators. They also decrease the tubular glomerular feedback activation, which causes vasoconstriction. They release nitric oxide, which then causes vasodilation. And they reduce the afferent arteriolar resistance. So all this will eventually result in increased renal oxygen delivery. And if you look at the pathophysiology, right, we know that as I mentioned earlier, most of the earlier interventions in the guidelines really look at trying to reduce vasoconstriction. But what amino acid is trying to do is to address the reduced renal perfusion, to increase the renal perfusion so that there's no AKI. So we did this study. Basically, it's quite simple. It was 3,500 patients who had undergo cardiopulmonary bypass. They started to stay in ICU for at least one night. We randomized 1,750 to receive amino acids and 1,750 to receive crystalloid, which was Hartmann solution. And you can we use a mixed amino acid infusion. So this is what it consists of 15 amino acids, including alanine, arginine, and glycine, and several you can see from the list down there. These were elective on-pump cardiac surgery. We excluded patients who were really very bad renal function with GFR less than 30 because all on receiving renal replacement therapy. But other than that, most patients could qualify. So in the end, the study really looked at 3,511 adults. The median age was about 67, 70% men, and we compared them. And if you look that we ran the rate of amino acids from the start, from induction or anesthesia, ran it at 40 mils an hour, and until the point where they went out of ICU into high dependency. And for the study, it was basically around 30 hours of infusion, giving a total dose of 1.2 liters of amino acids, or less than 3 bottles. Most of the patients we stopped because they, 3/4 of them we stopped because they were discharged from the ICU. Some of them did the maximum dose of 72 hours. The kind of patients that we used were 1/3 CABG, 1/3 mitral valve, 1/3 aortic valve. Most of them had pretty decent pre-op creatinine, high normal pre-op creatinine about 85. As I mentioned, age about 66, and about 70% male. Normal injection fraction mainly with both groups. They were mainly 80% of them were NYHA 1 or 2. Duration of CPB for both groups were about 90 minutes. The amount of vasoactive drugs that were used, dopamine, epinephrine, and dobutamine, were same between both groups. Also the mean blood pressure were quite similar between both groups. Overall, the primary outcome was that the use of amino acid decreased AKI at hospital discharge by 5% overall, right? From 31% to 26%. And so that translates to a 5% absolute reduction and a 15% relative reduction, and the numbers needed to treat of 21. And you can see that in a graphical form as well, that the placebo group had more patients, or rather the amino acid group had more patients without AKI after 7 days. So the take-home messages here is that, well, we know AKI is a major health issue. As I said, one of the 3 main problems that causes patients to stay longer in hospital, stay longer in ICU. Before this trial, there was really no preventive therapy supported by any strong evidence. But I think after this very large trial, we have clearly shown that amino acids can increase through its method of increasing renal blood flow, increasing GFR, increasing renal medullary cortical oxygenation, and recruit renal function reserve. That in this large randomized controlled trial, that infusion of amino acids really reduced the occurrence of AKI. And again, it was a 5% absolute risk reduction, a 15% relative risk reduction, and with a numbers needed to treat of only 21. So I think going forward, we will try to implement this as much as possible. It's easy to perform. You just start the infusion, and when you start anesthesia, and you run it until the patient leaves ICU, or up to 72 hours. It is effective and safe. In our study, we didn't really see any adverse effects at all. It's relatively cheap. Okay, each bottle of amino acid is $5 US, $5.13 US, compared to renal lactate, which was 67 cents US. Most patients receive 3 bottles, so it will cost about $15 US more per patient. But you only need 21 patients, or $300 US to prevent 1 AKI. So I think probably if you tell your hospital administrator, it's probably worth the money. I think if you want to start, you should start with older patients. They seem to be the one that benefit. The higher benefits are seen in the older patients. And the biggest reduction, in fact, was the patients who were a little bit sick, were a little bit worse kidney function, the kidney goes stage 3, right? We are intending, our group is intending to do follow-up studies in critically ill patients and major non-cardiac surgery, but we really expect the results to be same. So with that, I thank you for your attention. I ran a couple of minutes over my time. Apologize for that. My email is there. Please, if you want to participate in renal AKI trials or you want to find out more, please just do email me. Thank you very much. Right. Okay, so we have a couple of questions here. Dr. Smriti, you want to take the first one? I would like to ask Dr. Smriti, are there some fatal consequences of misdiagnosis between postoperative delirium and other causes of acute confusion? That's a very good question.
Sorry, can
you see the question on the chat? They ask, are there any fatal consequences of misdiagnosis between post-op delirium and acute confusion? Which means that
so yes, I think misdiagnosing post-operative delirium as another cause of like acute confusion can have serious and potentially fatal consequences. Like if we cannot rule out the medical causes, like if sepsis, hypoxia, metabolic imbalances, or even intracranial hemorrhage, these all require urgent intervention. And if we mistaken POD for like psychiatric agitation instead of these underlying medical causes, and instead of addressing this, like for hypoxia, instead of addressing the hypoxia, if we give more sedation and more antipsychotics, then the patient can have like fatal consequences.
Okay. Do you have any personal anecdotal experience with that at all?
Like we had one patient, and then the PO2 was low, and then he was showing the sign of agitation, but we could catch with ABG that he had a low PO2s around 40s to 50s, and then we put him on BiPAP and with oxygen like 70 to 80%, and after a few hours the oxygenation improved, and then his confusion also started improving. So we could see like acute changes.
Okay, there is a question to me that says whether amino acids can be used in pediatric patients. As I said, this study was done in adult patients. We just don't have the information, so I have no experience using it in pediatric patient population at all.
Dr. Lianka, there are a question with Bahasa Indonesia. The question is there any informative about the use of amino acid in patient with CKD? So the patient already on CKD.
Yeah.
Is it still necessary or not?
Yeah. So that is a very good question, because as you know, in this study we did not use CKD4 or patients with CKD4 or CKD5 because we felt that probably the benefit was not there, and the reason is that if already patients with CKD, they have less nephrons remaining, and so their RFR, their renal function reserve, would be much lower. So what we did was that we looked in our data, of course, as a secondary publication, which we published in Anesthesiology last month, or 2 months ago, in the December issue of Anesthesiology, where we look at it at the patients who had CKD3. That means their eGFR at the start was between 30 and 60. And as it turned out, they were about equal in both groups. And then we showed that there was a benefit even in these patients. But as this association this trial was not meant to look at just CKD, so we probably need more information. So it does seem to be. So one of the theories that we're working is that maybe some of the amino acids may have direct effects other than recruiting RFR, that they either reduce inflammation or that they increase the they have like, for example, for whether they help in the utility of ATP or they cause vasodilation. Yeah, but we still need another trial. But the secondary analysis, at least retrospective data based on this trial, showed that yes, it is useful even in patients with CKD3. Okay, Dr. Aldi, there's a question which I cannot understand. Okay. While we're filling the time, maybe I ask Dr. Smithy a question. One of the things that we noticed also, we also look at delirium over the last many years, and one of the things that we've noticed is that our delirium rate has come down a lot. When I did the study maybe 10, 15 years ago, we had a delirium rate in Singapore about close to 20%, about 16%, 16 to 70%. And right now I'm doing another study where we are trying to look whether physiotherapy and behavioral therapy or occupational therapy, actually decreases delirium. And right now we find our delirium is somewhere around 5%. So I think a lot of the things that you have mentioned, a lot of anesthetists have started doing that as a routine basis, and because of that, overall the delirium rate has really come down. At least in my hospital, it's really come down. It's quite hard to do a study on delirium right now because the incidence is 5% or less. I don't know whether you see that trend as well in your practice.
Actually, I don't have the exact data, but clinically, we've also seen like the delirium is much reduced after like implementing and actively being conscious that this can happen in our ICU. So we do daily assessment, which was not done before. And then we involve nurses because they are the first, they are there all the time. And then if there is like any changes, they can report to us. So if we catch early, then we can like implement the measures, preventive measures, so that it won't be like full on agitated patients. So I think we don't have exact data, but we have reduced incidence from before.
Yeah.
So like, what do you do for the prevention of POD in your practice?
Yeah, we do a lot of things that you mentioned. Very nice, comprehensive things that you mentioned. We try many of the things. I think there are quite a number of us that actually run dexmedetomidine. We start dexmedetomidine without a loading dose, just before bypass, and we continue into ICU. So that has become quite common. Of course, midazolam use has gone down tremendously. We're using a lot of this now. We're using a lot of cerebral oximetry. And I'm not sure how much of contribution those do, but certainly that has helped. The awareness that people are, I think mainly because people are aware. People are aware that you avoid hypotension, like you said, avoid hypertension, avoid hypothermia, and do all the things that are correct. And we've definitely seen it drop a lot. The numbers are really down. Yeah.
The other thing is, once the delirium is already present, so which medications, usually beside non-pharmacological intervention, which medication do you think work better?
Once established, I don't think anything works. Yeah. I mean,
what do you usually use for those agitated patients?
Dexmedetomidine.
For acute, like who are agitated, pulling their lines, I think dexmed takes little bit time to work.
That's true. Yeah. That's a bit difficult. I think that one really, like was mentioned, that you mentioned earlier, is really to try to solve the underlying issue, the underlying cause, address the underlying cause, make sure the patient doesn't harm himself. But to after that, obviously dexmedetomidine hopefully will then resolve it over time. Yeah.
Okay, thank you.
So there is a question for you, Dr. Miti. Do you have any experience using neuropeptide like Samac for? I'm not familiar with this. Do you know?
No, actually, I'm hearing this for the first time. Neuro. I'm sorry.
Yeah, this kind of drugs is usually used in Indonesia. I don't know the origin. I think the origin is from Russia or something like that. So they give intranasally, and then the progression is quite good. The patient usually getting better from patient with cardiac. I'm sorry, stroke hemorrhagic or something like that. But yeah, I have no experience to use in cardiac surgery. Thank you.
Okay, interesting. Okay.
Thank you. If there are no more questions, I thank all the speakers. Dr. Grace Catalan, thank you very much for spending the time with us. Dr. Now I know, Kui Tanyan, I know I'll pronounce it properly. Thank you very much, Dr. Kui Tanyan, and Dr. Smitry and Dr. T for spending the afternoon sharing your research work. Thank you. Thank you. Can we have the emails out, Padatin? Would you be able to flash that?
Okay, yes. Mil minta tolong share slide email.
And then Dr. Aldi will make an announcement about the coming Asca meeting in Bali. Okay. Aldi, would you be speaking on this?
Oh yeah, sorry. Yeah.
Yeah.
Yeah. So Asia meeting 2025. So for pre-congress workshop, 1st July and 2nd July 2025. The symposium is 3rd and 4th July 2025. Don't forget Jimbaran Convention Center at Intercontinental Hotel Bali. Thank you.
Okay, good. Do you have the emails of the speaker? If not, I can do the share screen.
Speaker emailnya, Mil. Slide.
Would you like me to do the share screen or you share yourself? Okay.
Bisa Erga?
I'll do it. I'll do that.
Okay.
I'll do that. Oops. Okay. I'm just going to share this information with everybody. So this the speakers have already given me permission to share. So this is a affiliation and the emails of the speakers for this afternoon. So they welcome communications with participants and the audience. And if you want further information from them, feel free to write to them and you can build your network like that. Thank you very much. I'll leave this for another 30 seconds. If you're interested in today's topic and you want to find out more, or if you're interested in doing research with these colleagues, go ahead and write to them.
I have questions to Dr. Audi about the pre-congress workshop. Could you please promote what is the example of the pre-congress workshop in Asca, Bali, please?
Okay, you can see the detail at the website, but we have a TTE workshop, TE workshop, hemodynamic monitoring, ventilator support, and so on. So we have a lot of kind of we have 7 kind of workshop there. Okay, thank you.
Good. Okay. All right then. No more. We'll close this webinar for this afternoon. Thank you, everybody who participated, especially the huge number of supporters from Indonesia. You can see that today we have got over 500 participants. Okay, see you all in July 1st to the 4th in Bali. See you. Thank you. The committee members can stay behind. Thanks. Aldi, you switch off to the panel.
Oke, wait. Erga bisa tolong nggak dijadikan ini biasa lagi? Stop recording, stop share.
Have you switched on to the panel now?
Kembali ke practice session bisa nggak? Mile?
Bentar dong.
Nggak bisa kayaknya dok, harus di encet dulu,
Oh,
webinar dulu.
sorry Nianci, I think we have to end first and then come back again.
We
Ya,
can.
pas yang
Sure.
link meeting ya, yang share.
Sure. So we sign out and then come back in again, or what? Or she can close the meeting.
Yeah. I think I will share the another link to here. Okay, wait. Only for panelists. Okay.